Good morning, Wow. Good morning, everybody. Welcome to Cardiology Grand Rounds. I just have a couple things to say before I hand it over to Chris Longnecker to introduce our speaker today. The first is to just point out from a logistics perspective that next week will be our last Cardiology Grand Rounds of the academic year. So everybody can clear their Friday mornings for the rest of the summer, and we will see you back the first week of September for the upcoming year of our Cardiology Grand Round series, which is really exciting. We have a really great speakers already getting scheduled for the fall. So thanks everyone for your participation in Cardiology Grand Rounds this year. Second, I just want to thank Jennifer Hanberg, who has provided all of our administrative support, gets here very early, and makes sure that this runs. And so thank you, Jennifer. All of you should appreciate her efforts. Next week will be a presentation by our Laughlin Award awardee. But this week, we're fortunate enough to be able to have the speaker be the recipient of the Otto Fellowship Award. And I just want to say a couple things about Catherine, who couldn't be here today, but I know she is online. So hi, Catherine. You can turn down the volume so you don't have to listen about yourself. But if you don't know Catherine well, I mean, you certainly know her by reputation. Really one of the world's leading experts on aortic and valvular heart disease, as well as a leader in the education space, the inaugural program director for our fellowship, and who led that fellowship for 20 years, the current chair of the ACC/AHA guidelines committees, and just a deep commitment to education, which I think is really represented by this annual award to one of our fellows who's really excelled in the world of clinical care, education, and hopefully following in Catherine's remarkable footsteps. So without anything else, I'll hand this over to the good Dr. Longnecker, who can tell us a little bit more about our speaker today. Thanks.
Thank you very much, Greg. So everyone knows Cooper. So it's really difficult to introduce someone that everyone knows so well. So I've opted to take more of the graduation season remarks approach. And so I'm going to repurpose some remarks I made for the Fellows Research Celebration a couple weeks ago. So Cooper, what a pleasure it has really been working with you for the last couple of years as part of a group of us, really, that is passionate about clinical and health services research related to methamphetamine cardiomyopathy and heart failure. You're going to be a fantastic addition to the Harborview faculty as a clinician scholar. Together with other clinician scholars like Danny, Renal, and others, I fully believe you will make important contributions to this important and emerging field of science. In addition to registry-based observational research, you've learned how to do other things like bibliometric analyses, and you've even ventured into qualitative research. And these concrete skills will serve you well as you seek to improve outcomes for people living with methamphetamine-associated heart failure. I've really been impressed by your enthusiasm that you've had in writing an R13 NIH conference grant with me to fund a national conference next year to be held here in Seattle in June of 2026 on research priorities for meth-associated cardiopulmonary disease. And you've already secured NHLBI and NIDA pre-approval for that application. Cooper, thank you for being the amazing person that you are, and I look forward to working with you as a colleague for years to come. It's over to you. And actually, I have the honor of giving you your certificate for the Otto Research Award. Congratulations.
Thanks, Chris. Appreciate it. Thanks, Chris, for that very kind introduction, and thanks to everyone for being here, both in person and on Zoom. And I'd also like to take a second to thank Catherine, both for her support of my scholarship this year, but just generally for always being there for the fellows, whether it's in the Echo Lab or giving us sage career advice. I think it's been really helpful to have someone like Catherine in our corner during this fellow to faculty transition. Without further ado, all right, I have no financial disclosures relevant to this talk. I would like to start with some scholarly disclosures. As Chris mentioned, this talk really builds on the phenomenal grand rounds that Dr. Hidano gave about a year ago on the same topic. And I want to expand upon her work and mention some of the research that we've been doing together as a team. Full acknowledgements will be at the end of this talk, but all of this work has happened in a team environment and not in a vacuum. And a brief word on abbreviations. I'll define abbreviations slide by slide, but one abbreviation I'll use throughout the talk is MAHF for methamphetamine-associated heart failure. My objectives for this talk are that by the end of the talk, I hope everyone appreciates the challenges inherent to the study of methamphetamine-associated heart failure. I hope that everyone's able to discover the breadth of research going on at the University of Washington in this area to address these challenges. And finally, I hope to spark some enthusiasm for the future of the study of methamphetamine-associated heart failure. But first, before I ask you all to dedicate the next hour of your lives and potentially the next 30 years of my life to this topic, why should we care? Methamphetamine use is incredibly common. This data comes from the National Survey on Drug Abuse. And in the year 2023, 2.6 million people used methamphetamine and 1.8 people had bona fide methamphetamine use disorder. To put methamphetamine-associated heart failure in the context of heart failure in general, the prevalence of heart failure in the US is around 2%, but the prevalence of heart failure in people who use methamphetamine is 4%. So methamphetamine use increases risk of heart failure by about 50%. And from data from the National Inpatient Survey, which identifies inpatient admissions based on ICD-10 codes, in the year 2023, an estimated 222,000 patients sought inpatient care for methamphetamine-associated heart failure. So this likely underrepresents the total number of people living with methamphetamine-associated heart failure in the United States, since it doesn't capture people in the outpatient setting. Furthermore, patients with methamphetamine-associated heart failure have worse outcomes when compared with heart failure in general. This data is from UCSD, from their center, showing higher rates of heart failure readmission for patients with methamphetamine-associated heart failure. And even more data. This is from data from California showing that patients with methamphetamine-associated heart failure have more hospitalizations per patient, longer lengths of stay, and higher healthcare expenditures per patient. And I think this is sort of a thought experiment to put methamphetamine-associated heart failure in the context of another cardiotoxicity that we see quite frequently, and that's chemotherapy-related cardiotoxicity. So these numbers are a little bit more of a back-of-the-napkin calculation because I couldn't get the exact numbers of people with chemotherapy-related cardiotoxicity, but 4% of Americans have undergone cancer treatment. There's an unknown number of that treatment that is cardiotoxic, but the literature reports a 5% risk of clinical heart failure for patients exposed to anthracyclines. So at most, there are over 600,000 people with chemotherapy-related cardiotoxicity in the United States. And that's a larger number than 200,000, but I think at least in the same ballpark. And given the high burden of disease in patients with chemotherapy-related cardiotoxicity and the expertise required to treat these disease processes, cardio-oncology has their own subjournal of JACC. There are guidelines for cardio-oncology from the ESC, and there are dedicated meetings to get people dedicated to this field in the same room and talking about this topic. I think for people like myself who consider themselves to be addiction cardiologists, the emergence of these subspecialties within cardiology is really exciting. ACHD, structural heart disease, and cardio-oncology were all born out of clinicians identifying specific patient needs that were unmet and working endlessly to meet those goals. And my hope is that addiction cardiology can follow in their footsteps. All right, now let's jump into the challenges inherent to the study of methamphetamine-associated heart failure. So first off, there's a really heterogeneous definition of the disease process and lack of consensus diagnostic criteria. This is a meta-analysis that the Stanford group published trying to meta-analyze 21 studies about methamphetamine-associated heart failure. And what I've highlighted down here in the results section of their abstract is that they actually could not combine the results of their meta-analysis due to heterogeneity in study design, patient population, comparators, and outcome assessments. And if you look at the abbreviations used throughout the meta-analysis, they've abbreviated methamphetamine-associated heart failure as METH-HF. I'm calling it MAHF. Many people will call it METH-REF. It's a small point, but at present, we can't even agree on what to call the disease process, which makes it hard to study the disease process. In the meta-analysis, they go on to, describe where the heterogeneity is between all these different studies. And there's three main sources of heterogeneity. First is how the disease process is defined. Some studies will define methamphetamine-associated heart failure as clinical heart failure with methamphetamine use. Other studies require that no other etiologies of heart failure are identified through a thorough diagnostic workup. The definition of methamphetamine use is similarly variable between studies. Some studies just require a positive urine drug screen, whereas others require an ICD-10 code for methamphetamine use disorder. This point's important because urine drug screens are very commonly falsely positive for methamphetamine if patients are on pharmacotherapy such as mixilotine. And then the ejection fractions included in the studies are also variable. And so this meta-analysis was accompanied by an editorial from Jonathan Davis, who's a leader in this field at UCSF. And I think the quote really summarizes my thoughts very well, that understanding this heterogeneity is critical. As Manja et al. Have shown, it is very difficult to study something without a clear consensus on a definition. So how are we going to study a disease process if we don't know what we're studying? And so from this sort of pondering, what are we calling this disease process? What is methamphetamine-associated heart failure? Came the inspiration for our first research project that I want to mention today. Broadly speaking, the research question is, are we assessing for alternative etiologies of heart failure in patients with methamphetamine-associated heart failure? I think probably the purest definition of methamphetamine-associated heart failure is clinical heart failure, methamphetamine use, and no alternative etiology of heart failure identified. And an ischemic evaluation, since it's routinely done for new onset heart failure, seemed like a good thing to study, especially with coronary disease and ischemic cardiomyopathy being the most common cause of heart failure. There's also, I think what makes this research question even more interesting is that there's some mouse model data and human autopsy study data that shows that methamphetamine use actually accelerates atherosclerosis through activating inflammatory pathways and acting on the endothelium. And so we're left with this kind of interesting relationship here where methamphetamine use is directly cardiotoxic and causes cardiomyopathy, but it also accelerates atherosclerosis, and atherosclerosis is the most common cause of heart failure in the United States. And so our research question for this project lies in this bottom arrow here, asking the question of, well, how often are we testing to identify coronary artery disease in patients who use methamphetamine and have heart failure? We hypothesized that patients with methamphetamine-associated heart failure would undergo ischemic evaluation less frequently than patients with heart failure who do not use methamphetamine. And I have to give a lot of credit to Danny Hedano for this project because the data from it came from the retrospective database that she started. So all the patients came from our hospital system. In the methamphetamine-associated heart failure group, patients had to have heart failure symptoms, an EF of less than 50%, a positive urine drug screen, and then we did individually adjudicate through chart review that they did in fact have methamphetamine use disorder. We had 75 patients in that group, and then our heart failure control group had the same criteria, but no history of stimulant use. Patients were matched one-to-one with respect for age, sex, and race, and an ischemic evaluation could be either an anatomic evaluation or functional testing. Ultimately, every single patient except for one underwent an anatomic assessment with either coronary CT or coronary angiography. Here is the table 1 from our work that was published in JAHA last year. You can see that the patients are very well balanced in terms of demographics and their mean ejection fraction. Where they differ is that the heart failure control group had higher rates of traditional atherosclerotic risk factors, and the methamphetamine-associated heart failure group had higher rates of comorbid substance use disorder. And here is the primary figure from our work. And so this figure represents the cumulative event rate of undergoing an ischemic evaluation from the time of diagnosis of heart failure. And you can see that there's an incredible difference between the two groups, with only 18% of patients in the methamphetamine-associated heart failure group undergoing ischemic evaluation, as compared with 85% of patients in the heart failure control group. Patients were followed, or we had follow-up data for up to 240 days in these patients, which we felt was enough because, as you can see, the majority of these ischemic evaluations are happening during the index hospitalization for heart failure, with the median time to ischemic evaluation of 3 days in the methamphetamine-associated heart failure group and 4 days in the heart failure controls. And, I think in the era of data from revived BCIS2, time to ischemic evaluation is not the ideal quality metric in heart failure. I think time to guideline-directed medical therapy is probably a better metric. But what this data does show is that for a diagnosis that should be a diagnosis of exclusion, patients with suspected methamphetamine-associated heart failure are not undergoing evaluation for alternative etiologies of heart failure. And from this project, the next step in our collective work was, well, we don't have common language for this problem. Folks are not undergoing a standard workup for this problem. How do we get everybody on the same page? And collaboration in general leads to uniform terminology, because communication between different groups in different parts of the country or from different institutions necessitates a shared language and a shared vocabulary about a problem. And you can imagine one person on their own in their office studying this saying, oh, let's call this meth heart failure. Whereas two people getting together have a discussion and they say, maybe it should be methamphetamine-associated heart failure. But if you get all these people who are excited about this problem and have different perspectives and different knowledge in this area in the same room, maybe people start asking deeper questions of, oh, what are the diagnostic criteria? What really is this problem, and how can we treat these patients better? And in cardiology, we're no strangers to collaboration. We, as a field, have the most guidelines of any field. The ACC/AHA even published guidelines in 2014 just on what terminology to use in clinical trials to make sure that everyone was on the same page and using shared language for endpoints of clinical trials. Even less common disease processes like cardiac sarcoidosis, while they don't have guidelines, they have AHA scientific statements proposing diagnostic algorithms and standard of care. This scientific statement was probably co-authored by Richard Chang and Chris Patton. And since I'm the Auto Clinical Fellow, I would be remiss to not mention Catherine's valve guidelines, which I have to reference in clinic every time I see a valve patient. So I have never been a part of writing guidelines, but I would imagine if you get a lot of different people from different institutions with different multidisciplinary backgrounds into a room, over the course of that process, a shared language is developed and a consensus is reached. So how can we study collaboration? What is there a mechanism for studying collaboration? We ended up using a bibliometric analysis to answer this question. So our broader research question was, are the research efforts in methamphetamine-associated heart failure collaborative, or isolated efforts? And a bibliometric analysis essentially summarizes and visually represents bibliometric data. It's able to generate unique statistics, and it has been successfully applied to many medical fields. Our hypothesis was that there has been an increase in publications about methamphetamine-associated heart failure without an increase in collaboration. And so to do this study, we used a broad PubMed search to make sure we didn't miss any articles about methamphetamine-associated heart failure. Each article was individually reviewed for relevance. So we started with 530 articles and ended up with 136 articles. And when the publications were graphed per 5-year time period, you see that there has, in fact, been a very significant increase in publications about methamphetamine-associated heart failure centered around the year 2015. This is not entirely surprising because this data is also from the National Inpatient Survey. 2015 was an inflection point for the methamphetamine-associated heart failure epidemic. So you can imagine clinicians out in the world seeing patients afflicted by this condition and wondering, how can we better treat these patients? How can we better take care of these patients? And then turn into research to try to advance their care. And this is the central figure from the bibliometric analysis. If you don't, I'll take you through it. Essentially, every dot on the map is an author or a node, and every line is co-authorship. So 2 dots combined by 1 line would be a paper written by 2 people. And each of these individual clusters are co-authorship clusters. And the uniquely colored clusters, if you look at the institutional affiliations of the authors, they essentially map perfectly to the author's institutional affiliations. And this is backed up by the quantitative statistics that the bibliometric analysis showed, that there is very limited collaboration in the field of methamphetamine-associated heart failure. And you have people publishing on this topic in institutional silos, but not much cross-collaboration between institutions. Furthermore, if you look at the institutional influence of each institution, this is a map where each point is an academic institution, and the size of the dot is basically correlates with the number of publications out of that institution. and it's mapped on top of the prevalence of methamphetamine-associated heart failure. So in the West and Mountain West, there's the highest prevalence. In the Midwest, there's it's slightly less prevalent, and then in the South and Northeast, there's the lowest prevalence of disease. And what you see is that in general, the highest impact institutions are in areas of high disease prevalence. So Hawaii, UC San Diego, UCSF, Stanford, the University of Washington's DOT is growing. But despite that, there is really national interest in this area. So even in areas with low prevalence of disease, people are interested and people are researching this. And so from our takeaways from our bibliometric analysis are that there's been a significant increase in scholarly interest about methamphetamine-associated heart failure in the last decade, but that these research efforts are largely isolated in institutional silos without significant collaboration. And while the highest impact institutions are in areas with high prevalence, broad interest remains across the country. So to summarize what we know about the first challenge in this area, the heterogeneous definition of methamphetamine and methamphetamine-associated heart failure and lack of diagnostic criteria, our work has shown that there are low rates of ischemic evaluation. Thus, we are not assessing for alternative etiologies of heart failure, and similarly, low degree of collaboration in this field, which could be contributing to a lack of uniform language about this problem. More to come about what the next step is to try to enhance collaboration in this area, but I'd like to pivot to the second challenge in this area, which is that people who use methamphetamine face stigma in the medical system and are really disproportionately affected by social determinants of health. And that brings up the question of, well, can we reduce stigma and address social barriers for these patients? Pretty much every study on methamphetamine-associated heart failure has shown that this patient population has higher rates of poverty, housing instability, comorbid mental illness, and you can imagine that creates barriers to the traditional model of healthcare, where we ask patients to show up at a specific time in a specific place in a very regimented way. And so I think given the social barriers that patients face and the stigma that these patients have historically faced in the medical system, it's really crucial to incorporate patient perspectives into our research and allow that to drive research questions and clinical care. There is not much in the literature about patient perspectives. The one study the one qualitative study came from the Heart Plus Clinic in UCSF, which was co-founded by Sarah Leidy, who is an addiction medicine doctor at Harborview, and Jonathan Davis. And the clinic model was that it was a co-managed clinic. Patients would see a cardiologist and an addiction medicine doctor in the same day. And the premise of the clinic, or the addiction treatment strategy that they used, was contingency management, which is essentially a behavioral therapy that incentivizes target behavior. So clinic attendance or negative urine drug screens with rewards. And at the end of a 12-week pilot, they asked their patients, they did a qualitative research analysis and asked their patients what worked about the program and what didn't work. And the themes from the qualitative study were that a real pro of the program is that they felt like they trusted their clinicians and they were receiving destigmatized care. And another theme that arose was that social barriers in the instances where patients did miss appointments, it was generally due to social barriers as opposed to not wanting to engage in care. And you can imagine how if you're unstably housed or sort of living paycheck to paycheck, it could be incredibly challenging to put those things aside and go to a medical visit. And so I'm excited to announce that Dr. Leidy is leading a larger qualitative study at Harborview, and she's partnered with some of us in cardiology to do this work. We're in the early stages, but we have IRB approval, and so we'll be doing this work over the next year. The research questions that we're trying to answer with this study are what is the lived experience of people with methamphetamine-associated heart failure? What is the impact of stigma on patients' care? How does methamphetamine use impact heart failure care? And what are some of the challenges of heart failure management? So more to come on that. At the University of Washington and Harborview, fortunately, we have really dedicated clinicians who did not wait for data to show that doing this work is important and impactful. I want to highlight the Community Heart Failure Program, which I think everyone at the University of Washington is familiar with at this point. But Jamie and Kate started this back in 2023, and Mernal has joined them. And at this point, they have a patient panel of around 100 patients. And the ethos of the Community Heart Failure Program is trauma-informed care. And trauma-informed care is an approach to healthcare that recognizes that patients have suffered trauma in the medical system and aims to create a safe and supportive environment. The Community Heart Failure Program has really achieved a lot by just bringing heart failure care from the clinic, from the traditional model, into the community and really meeting patients where they are and trying to address some of those social barriers to care. This flowchart on the left here is from one of their recent publications where they demonstrate that through trauma-informed care, building trust with their patients and shared decision-making, they've been able to reduce hospitalizations, ER visits, and hospital length of stay, improve patient outcomes, patient-reported outcomes, and improve biomarkers and medication adherence. Some other scholarship that has come from the Community Heart Failure Program. Wanted to highlight a case report that Joey Chang, who's a medicine R3 and soon-to-be hospitalist, wrote. This is a case series of patients in the Community Heart Failure Program who recovered their EFs with the incredible care that the Community Heart Failure Program provides. And we've expanded this case series to 7 patients and included LV dimensions to show that that engagement in the Community Heart Failure Program and improved medication management can lead to recovery of LVEF and a decrease in LV end-diastolic volume indexed over time. This work will be presented at ACE this coming year. And so the Community Heart Failure Program has really been able to accomplish this sort of circle of positive reinforcement where through trauma-informed care, they have gained patient trust. Patients are then more likely to engage in care. With more engagement in care, you have improved GDMT use. This leads to an improvement in LVEF. Patients feel better, and when patients feel better, they trust the process more, and it just sort of continues to cycle in a positive way. I think I was lucky enough to ride along with Kate and Jamie a few months ago on a half day of clinic and was really inspired by the work they do. But one question that came out of that is a lot of patients with methamphetamine-associated heart failure are presenting pretty late in the disease process. We see very young patients with very low EFs. And so another research question that others and myself have had is, can we detect methamphetamine-associated heart failure earlier? This data here is from one of the the original studies of methamphetamine-associated heart failure, which came out of Germany, and they followed 20 patients over time, and each patient had an endomyocardial biopsy at the time of diagnosis. And what they showed is that, as you might expect, with methamphetamine cessation, people's EFs tended to recover, but the likelihood of recovery depended upon the degree of fibrosis at the time of diagnosis, which makes sense. The more scarred down your ventricle is, the less likely it is to recover. Which brings up the question of how can we detect this disease process before patients have fibrosis? And so I've been fortunate to play a small role in a much larger project, the Pure Heart study. Pure Heart is one of 5 projects in Chris's larger rural ProCare Health Equity Network, and it's sponsored by the AHA. The study is based at OHSU, but University of Washington is the coordinating center for all 5 studies. And OHSU has partnered with Bay Area First Step, which is a peer substance use recovery organization in rural coastal Oregon. So I've been involved in this project for the last 2 years as a trainee. The basis of Pure Heart is actually work that this same OHSU group did called Pure Telehep C. And so before going into the next few slides, I wanted to define what a peer is. A peer is an individual with lived experience living with addiction. And so Pure Telehep C it was a clinical trial that randomized patients who use drugs and have hepatitis C to either peer facilitated telehealth or enhanced usual care. And the results are here in the bar graph. The enhanced usual care group in red, over 80% of them did not even initiate treatment for hepatitis C, and less than 10% achieved sustained viral remission, which is the goal for hepatitis C treatment. Whereas the pure facilitated telehealth group had over 80% patients initiated on treatment and over 60% who had sustained viral remission. And so this study shows that peer navigation and telehealth can be effective strategies for treating the medical complications of addiction. And so Pure Heart is the goal of Pure Heart is to screen for methamphetamine-associated heart failure. For those of you who not familiar with Oregon geography, the study takes place in Cook and Curry County, which is down here in the southwest of Oregon, and that's where Bay Area First Step works. And then the telecardiology is provided by OHSU. The aims of this study are first to adapt and implement a peer-directed methamphetamine-associated heart failure screening program for people in rural communities. Secondly, to pilot a peer-facilitated telecardiology versus usual care to enhance linkage to cardiology care for patients with methamphetamine-associated heart failure. And then third, to do a qualitative analysis of what worked and what didn't. What were the barriers to implementation? And there's a precedent for screening for heart failure. The STOP-HF trial in 2013 looked at BNP-based screening for patients at risk of heart failure. And so this essentially randomized patients with stage A heart failure, some risk factor, hypertension, obesity, valve disease, atrial fibrillation, to either BNP-based screening or usual care. And if folks in the BNP-based screening group screened positive, then they underwent team-based risk factor management with their primary care physician and a cardiologist. And after a median of 5 years of follow-up, there was a significant reduction in both clinical heart failure and reduction in EF in the intervention arm. So this has shown that BNP-based screening is effective for detection and even prevention of heart failure. And so for Pure Heart, we're essentially substituting methamphetamine use for cardiovascular risk factors and using a similar strategy. The screening protocol is that the peers at Bay Area First Step will screen their clients who use methamphetamine with point of care BNP, a point of care ECG from the Cardia mobile device for QRS duration, and a symptom questionnaire. If patients screen positive, then they'll be consented for the trial, and then they'll be randomized to either pure facilitated telecardiology with a cardiologist at OHSU, or enhanced usual care, which is in the form of a letter to their primary physician explaining the screening results and leaving the referral to cardiology up to them. And we're in the early stages of the study, so don't have any results to share with you all. But I think that it's an incredibly innovative and exciting study design, and I think one of the cornerstones, I took this slide from Chris, but one of the cornerstones of the Rural ProCare Health Equity Network, Research Network in general, is reciprocal innovation. The idea that we can use implementation strategies that Chris and others have studied in global cardiology and where there are resource limitations, and apply them to the rural United States where there are similar resource limitations. But there's really all kinds of reciprocal relationships in medical practice, rural versus urban, practice versus academia. And so I think the results of this trial will be incredibly informative for our practice here in Seattle. And you can imagine if BNP-based screening is found to be effective in rural Oregon, why can't we be screening for methamphetamine-associated heart failure in the emergency room, in addiction medicine clinic, in primary care clinic, so that we can detect subclinical disease and really move to preventing methamphetamine-associated heart failure as opposed to treating and reacting to methamphetamine-associated heart failure. One final research question is, well, what happens when we don't pick up early disease? What happens when patients have advanced disease? The bar graph here is also from the German study of 20 patients, and you see that the vast majority of patients with methamphetamine-associated heart failure present with very advanced symptoms. 85% of patients in their cohort had NYHA 3 or 4 symptoms. But patients with substance use disorder have been shown to have higher mortality after LVAD and heart failure or heart transplant. And so active substance use is a contraindication to some of these advanced therapies. So you end up with a little bit of a management conundrum of, well, how do we best treat these patients when they have advanced disease? And to exemplify exactly how intense the management conundrum can be, I want you all to think about this case. You have a young patient with methamphetamine-associated heart failure who presents after VF arrest and is in biventricular cardiogenic shock. He's known to your institution. He's established with heart failure, but he does continue to use methamphetamine. And just think for a second, how do you treat this patient? I'd like to thank Dr. Azen, who's here, and Sinu Thomas for their help in writing up this case. This is a very oversimplification of how this patient was managed, but the patient was placed on VA ECMO for hemodynamic support. While on ECMO, Dr. Azen was able to do an addiction medicine consult and actually identified that he had numerous favorable factors in terms of his substance use and protective factors, namely that he had not been using for a very long time, he was motivated to stop using, and he had good social support. he was on mechanical support for quite a long time and was actually unable to be weaned from MCS. And so after many multidisciplinary discussions that have been simplified to an arrow, he underwent a durable LVAD. The durable LVAD, what it did really is it provided the hemodynamic support that the patient needed to engage in addiction medicine in the outpatient setting, which is really the optimal place to treat addiction. And with that hemodynamic support, he demonstrated 6 months of sobriety with Q2 week urine toxes. And given that he clearly was not recovering LV function and still had some hemodynamic derangements despite optimal unloading, he was ultimately listed for transplant and successfully transplanted. I ran into the patient a few weeks ago. Well, he was admitted after a biopsy, and he's doing well. Very thankful for the care that he's gotten, and we have written this up as a case report that is under review in JACC case reports. I won't belabor this since Sinu gave a phenomenal grand rounds on this earlier this year, but I think what has traditionally been called bridge to candidacy and what Sinu has coined bridge to opportunity is really lies in this relationship here where active substance use is precluding advanced therapies. And the sort of core tenets of the bridge to opportunity are that substance use is a modifiable barrier to advanced therapies, just like any medical comorbidity, hypertension, diabetes, and with appropriate medical treatment of that comorbidity, patients can become eligible for advanced therapies in select cases. And this is the central figure from our case report, just highlighting exactly how multidisciplinary the care of patients with advanced methamphetamine-associated heart failure has to be, and that while the primary cardiology team may change from stage to stage, being the heart shock team originally, the LVAD coordinators post-LVAD, and the transplant team post-transplant, addiction medicine is a constant because it's a lifelong disease. And the initial social work and palliative care assessments are crucial to outlining what a patient's social support is, and that social support is crucial throughout this journey. So Chris mentioned this briefly at the beginning, but based on what what are the next steps for this research? Based on what we found from the bibliometric analysis, and this limited collaboration in this field, we are applying for an R13 grant from the NIH. An R13 grant is NIH funding to support a recipient-sponsored conference. I've been to many national meetings and enjoyed them all, but every time I search the agenda, I tend to find that methamphetamine-associated heart failure is relegated to poster sessions, case reports, and so we've adopted the field of dreams mentality. If you build it, they will come. And our hope is that we can move from people speaking in isolation about this to getting a lot of really enthusiastic and dedicated people into the same room to have larger discussions and ask these deeper questions. We will be sponsoring the grant, but it's also co-hosted by OHSU and pulmonary vascular medicine because, as Yoni pointed out to me yesterday, methamphetamine also causes pulmonary hypertension. And I'm excited to announce that the application has been pre-approved by the NHLBI and NIDA. So stay tuned and mark your calendars for a year from now. To wrap up, here is a visual summary of our research efforts. And I think at the University of Washington, we are really leaders in this area and taking a multi-pronged approach to address this complex disease process. We're starting with patient perspectives with qualitative research. We have innovative care models in the community heart failure program and the bridge to opportunity pathway. We're involved in trying to learn how we can detect this disease process earlier with PureHeart. And in the future, we hope to have a scholarly meeting dedicated to methamphetamine-associated heart failure. If you're not a visual person, here are the takeaways in bullet point form. So take-home points, there are challenges to the study of methamphetamine-associated heart failure. There still is a heterogeneous definition, and we lack consensus diagnostic criteria. Patients face a ton of stigma and social barriers to care. But at the University of Washington, we have a multi-pronged approach to this complex problem. And I can't answer whether I've achieved the third learning objective, but I hope that this talk has sparked some enthusiasm for the future of the study of methamphetamine-associated heart failure. I know for me personally, this is just the beginning, and I am excited to continue this work next year as a faculty member at Harborview. As promised, lots of acknowledgements. I'd like to thank Chris for his incredible mentorship. I've learned a ton just from sitting in research meetings with you, hearing your thought process, how you approach research questions, and it's really been fun to work with you, so thank you. To Danny and Mernal and Sarah, I'm excited to work with you all at Harborview next year and be colleagues. To Jamie and Kate for their incredible work starting the community heart failure program. To Sanu and Dr. Azen for their mentorship on the case report. I'd like to thank the fellowship leadership. When I interviewed for fellowship, I said that I wanted to study methamphetamine-associated heart failure and work at Harborview. And I've accomplished those things with the incredible support of the fellowship. So thank you. To Catherine again for her support of my scholarship and all of us fellows. To Michael and Marta, my original Harborview mentors. To my co-fellows, it's been a joy to work with you all, and I've learned a ton from you all. To our collaborators at OHSU, both from PureHeart and for the R13 grant, Brian, Evan, and Todd, and Talitha and Jeff. And to my wife, Plessy, the better and brighter doctor in the Perez-Kersey household. I love this work, but it pales in comparison to our life with Woody and Barley. So thank you.
Well, congratulations, Cooper. That was an amazing talk. And it really shows how much you and the team has accomplished in the last year since Danny gave her talk. And we look forward to an equal amount of progress in the next year. So while others are gathering their questions, I'll start it off by asking, you've demonstrated there are some really mission-driven people trying to do really interesting things that are proving to be pretty effective. My question is, are any of those things scalable to the larger national problem that we have? And if so, what are some of the barriers that need to be addressed to make those strategies scalable?
I guess I've got one. Yeah, great question. I think the two sort of unique care models that stand out to me that show a lot of promise are community heart failure program, which we have here, as well as the idea of involving peers in navigation of healthcare, which the OHSU group is doing. And I think those are scalable. I think probably one of the barriers is that the OHSU work depends upon this incredibly dedicated group of peers at Bay Area First Step who have been doing this work for decades, and it's essentially easy for them to take a blood sample and do a point of care ECG because they already know and trust and have such trust from their clients. And so that I think they're truly an exemplary group of peers. And so I think one barrier to broader implementation is that some of these efforts depend on exemplary individuals or exemplary groups, Kate and Jamie, Bay Area First Step. And so local efforts may be limited by local resource availability. But I do think the models are scalable with the correct personnel.
Great. Other questions from the audience? Fareed?
That was an outstanding talk, Cooper. Can you tell me how do we go from using methamphetamine to the cardiomyopathy in terms of like some mechanistic things? And is it fair to say that we can just throw the same drugs we give to our other patients? Is there some opportunity for people who study like mechanisms to get into this business?
Yeah, it's a great question. I did leave out a lot of the background because of Danny's phenomenal grand rounds last year. And so the mechanism is sort of multifactorial, where there is direct myocardial toxicity from the methamphetamine, coupled with sympathetic overdrive, coupled with probably some atherosclerosis. And so I don't think, for someone like yourself who studies molecular mechanisms, I don't know if there is a mechanistic target. I think what we do know about the problem is that patients recover their ejection fractions either through guideline-directed medical therapy or methamphetamine cessation. And so it doesn't have to be both. The community, the 7 patients in the community heart failure program case series that I showed, the vast majority of those patients continued to use stimulants, but through the community heart failure care, had better GDMT uptake. Whereas the German data showed that if you just stop using methamphetamine, your EF recovers. But that, from my limited addiction knowledge, methamphetamine use disorder is very complex to treat, and there isn't good pharmacotherapy. So I think for treatment, we should be prescribing guideline-directed medical therapy, as well as engaging patients in methamphetamine cessation.
Yeah, thanks for that question. I'll maybe also add to that by saying that Danny Hidano has been funded with some LOCK funding to pursue the question of whether there are genetic variants that may predispose people to the development of cardiomyopathy. So it's probably maybe a 2-hit phenomenon, that sort of thing. Other questions? Anything online? Oh,
Dr. Lee.
Yeah.
That was great talk, Cooper, and phenomenal body of work, and congratulations on our 13th grant. You talked about actually a paper you published on ischemic evaluation for HFrEF patients with heart failure. Can you talk briefly on perhaps the barriers on why we're not achieving adequate ischemic eval? I know, like, for clinicians, when we take care of patients, I think back on minds is, what do we do if they get coronary angiogram? Because if they do get DAP therapy, then perhaps there's worsening outcomes than not achieving it. But what's your thought on perhaps how to address this? Is there education need to be done, or what your best take on achieving this disparity here?
Yeah, great question. I think one of the takeaways is just that heart failure plus methamphetamine use does not necessarily equal methamphetamine-associated heart failure. I think how to operationalize that clinically is challenging. In my practice, I think coronary CTA is a very useful diagnostic modality, because it's diagnostic for coronary disease, but you aren't faced with that intervention dilemma of, oh, if we find something, do we treat it? You can gather the information, see if coronary disease is contributing to the problem, and then as you get to know your patient a little bit better, what their life is outside the hospital, if they're able to take DAPT, then you can address those questions in a more with a little bit more time to think and engage a patient in what their preference is as well.
Well, congratulations once again, Cooper. Another round of applause, perhaps, and then we'll call it a day. Thank you, everybody.